Good afternoon, everybody. Thank you, John Bernard. Thank you for giving me this opportunity to show some of my job and my work. I'm Dr. Xue, and I'm a neurosurgeon and also a neuroradiologist. So I have some hybrid surgery experience. Today, my topic is spinal dural arteriovenous fistula. Spinal dural arteriovenous fistula are the most commonly encountered vestibular malformation of the spinal cord. They most commonly affect elder men and classically found in the thoracolumbar region. And the AV shunt is located inside the dural matter close to the spinal nerve root. The increase in spinal venous pressure led to venous congestion, and the clinical finding of the progressive myelopathy. SDAFs account for about 70% of all vascular spinal malformation, and estimation at 5 to 10 per million per year in the general population. Usually occurred in the this is occurred in the elder men. Men are affected 5 times more often than the women. The mean age at the time of diagnosis is 55 to 60 years. Most of the fistula are solitary lesions and are found in the thoracolumbar region. More than 8% of all SDAFs are located between T6 and L2. Low cervical DAFs are extremely rare. About 2% of patients have double spinal DAFs or a company of spinal pile or AV shunt. Sacral lesions. Lesions occur in about 4% of patients. High cervical lesions occur in 2% of patients. The foramen magnum region DAFs and the sacral region DAFs are two special types of the lesions. I will talk about these special DAFs sometime in the future, but not today. Initial symptoms of the venous congestion are non-specific and include difficulty in climbing. Yes, gait disturbance and more often sensory symptoms. These neurologic symptoms are progressive with time and are often ascending. Bowel and bladder incontinence, erectile dysfunction, and urinary retention are more often seen late in the course of the disease. Most diseases are slowly progressive, but acute onset are also possible. Spinal hemorrhage in our experience never occurred. The diagnosis rested on MR imaging, and it is confirmed by DSA because presenting clinical symptoms are unspecific. The neurologist is often the first clinician to raise the possibility of this diagnosis. The perimedullary vessels are dilated and coiled and can be observed on the T2 images as followoid, which are often more pronounced on the dorsal surface. Compared with the ventral surface. And CTA can demonstrate the physical localization. The CTA shows the AV shunt at the left T6, and the DSA confirm it. DSA can demonstrate the AV shunt. SDAFs have an apparent shunt zone with converging radicular feeders into the same drain veins. Yeah, that's the AV shunt, and in the operation we confirm it. Diagnosis of the confirmed cases. 8% experienced early misdiagnosis. Average diagnosis time is 18 months. So the MR imaging findings of cold edema together with perimedullary dilated vessels without any nidus, without any intramedullary nidus of the vessels are typically for SDAF, just the phlovoid and edema, not the nidus. Treatment. The aim of the treatment is to occlude the shunting zone. Surgical occlusion of the intradural vein is a relatively simple and safe intervention, exception of the sacral fistula. The endovascular therapy using a liquid embolic agent to embolize the feeding radicular meningeal artery is also a good method. But proximal arterial occlusion just can get a transient improvement of symptoms owing to the good collateralization of the dural. The fistula is proven to recur within the follow months. So I think only those patients who don't tolerate the open surgery should be treated with endovascular therapy. In our hospital, all the SDAFs have been performed in hybrid room since 2013. We used to have about 8 to 10 cases a year, and there has been an increase in cases in the last 2 years, about 15 cases a year. This a hybrid operation, DSA, precise localization of the fistula. That's the collector vein. That's root, the nerve root. Coagulating the vein and cut off the vein. Then all the lesions are disappeared. In a rare case, the anterior spinal artery may arise from the same pedicle as the feeder to the shunt. embolize this patient is extremely dangerous, and hybrid surgery may be considered safer approach. These lesions. We can see the anterior spinal artery after cut off the AV shunt. If we embolize this patient, it's very dangerous. Sometimes the SDAVFs have an extensive network of dilated perimedular veins. This network may even recruit supply from dural arteries that ascend or descend from the neighboring radicular meningeal arteries. See this multiple radicular meningeal arteries supply the lesions. And intraoperative DSA, when we cut off one AV shunt, we found there are some residual lesion. Then cut off all the AV shunt. If it is not performed in the hybrid room, there may be some residual lesions. And I have 3 cases experience of low cervical DVFs. This disease is very rare, but the surgical procedure is the same as thoracic lesions. See this DSA before the operation. That's a right cervical 5 level AV shunt. That's no rose. That's the winners, and that's the DSA immediately after the operation. Classically, the deficits here are slowly progressive, but an acute onset of the disease is also possible for this patient. For this patient, the symptoms is due to an extensive thrombosis of the descending perimedullary vein. See the blue vessel. That's a thrombosed vein. Then all the retrograde flow drainage into the ascending perimedullary vein, so the symptoms will quickly deterioration. That's the ascending vein. Cut the subarachnoid. That's a narrow root, a collective vein. Coagulate the vein. And cut off it. Then to the AV shunt is located inside the dural mater close to the spinal root. But in fact, the longitudinal collector system in the subarachnoid space at the dorsal and ventral surface of the cord, later joining the epidural space laterally through bridging or radicular veins. Please note the term bridging veins because let's see, just can see the vein. The veins can see the nerve root. Kind of the collector vein. Then you can see the nerve root here. The vein doesn't follow the spinal nerves. Yeah, this spinal root. The outcome treatment is aimed at halting the progress of the disease, and the prognosis is dependent on the duration of the symptoms before the treatment and pre-treatment disability. We have two cases who were complete paraplegia before treatment. Their lower limb muscle strength were only restored to level 3 at 6 months after operation, could not walk. In our experience, almost all patients have a regression of their motor symptom, and only 2/3 of all patients show an improvement of their sensory disturbance. In rare cases of long-standing SDOFs, patients may experience worsening despite the complete occlusion. But luckily, in our experience, never occurred. That's why occlusion. SDOF is a rare but treatable cause of progressive paraplegia. The aim of treatment in SDOF is to occlude the shunt zone. The AV shunt is located inside the dural matter, but not necessarily close to the spinal nerve root, because the collector system joining the epidural space, often through radicular veins, sometimes through bridging veins. Surgical occlusion of the intradural vein is a relatively simple and safe intervention. The hybrid operation can get an accurate location, small incision, and a reliable effect. Hybrid surgery can confirm the AV shunt by intra-operation select the DSA, avoid any radiolations. Thank you for your attention.
Okay, thank you very much.
Congratulations, Professor Xue.
Okay, Yuha, would you like to answer questions or comments?
Yeah, let it come.
Okay, panel, it's time to ask questions of Yuha.
Yes, sir. Can I ask a question, sir?
Oh, go ahead. Go ahead. Go ahead.
I want to know about the fistula's point, whether it is in the dural level or in the subdural level. The fistula lies in the dural sheet along the nerve sheet.
There are small arteries in the dura, and they fill the vein. So, where is the fistula? Is his question. It is inside in dura.
Yeah.
Small arteries inside the dura, and then fill the vein.
Yeah.
So I have coagulated also the dura, and then cut the coagulated fistulous vein, and then cut it. This has been my treatment. So what is your experience?
Sometimes I coagulate the dura, but
Hey, we can't see your face. Put your face in the camera.
Sorry.
Yeah. Okay.
So
That's better. Okay, that's better. That's better. Thank you. That's better. Okay.
is that okay
Yes,
with our answer, Mohammed?
Yes, sir.
Okay, good.
So should we coagulate the dura? That means dural nerve sheath, nerve sleeve, in the epidurally or intradurally?
I open the dura, and then I take the dura area which has this arteries. I coagulate on both sides. I take it. If you looked at the
Both
video,
sides.
I put my forceps in the both sides of the dura and coagulate. There are also recommendations you resect the dura, but this is not wise because then you have epidural bleedings. This is not wise. You should leave the dura and close carefully.
Sir, sometimes we have to sacrifice the facet joint to enter into the foraminal level to coagulate the epidural vessels. In that time, should we fix or fuse that particular level or not? No need of fusion or fixation.
This is thoracal. This is thoracal. You don't have to fuse. If you go one side, like I prefer, you can drill with diamond. Why do you fuse? This is not necessary. These are all the patients. If you open one facet, so you don't have to fuse.
Okay, Mohammed.
So yes, I have got another question, sir. When the radiculomedullary artery of Adamkiewicz arises from the same segmental level, what are the tips and tricks to do surgery on that particular level?
You tell. You tell. If the Adamkiewicz is at the same level.
Students one. Repeat the test.
Just tell.
Open again and with his.
Yeah, how to do when the Adamkiewicz is at the level. So you start the video. You are doing surgery.
Yes.
But didn't catch it.
Don't embrace this patient. It's very dangerous. Just do the surgery. It's very safe. You can see the venous, the arteries very clear. Just
Okay.
cut off the venous.
Okay, Mohammed.
Yes.
Okay, we have another comment. Luis Ibor Lopez from Spain. Are you there, Luis? Luis?
Yes, I am here.
Go ahead.
Hello,
Go ahead.
Louis. Hello.
Hello, Johan, congratulations. Hello,
Thank you.
everybody. Okay, some comments of the dural fistula. I am an expert in dural fistula because I started in Paris about in the past century in 1981 to 1986 with Las Junias and Urt. At that time is the era I don't have the MR. The diagnosis is with a myelography, contrast myelography. And the first point to check or suspicion of the fistula is to check the delay of the venous drainage in the anterior spinal artery. See, the delay is most the 20 seconds, you are a very high suspicion of the fistula, and you need to check every level. The second point is when I start to treat it by surgery in La Salpêtrière by Dr. Fox Alajoanin, to treat it the AVM in years 15 is remove the vein to the spinal cord vein, and every patient develop a total paraplegia. And the reason is don't touch the vein. The third comment is the diagnosis is very important, angiography diagnosis. You need every time check the anterior spinal at the same level. This is the reason in my experience, I need to procure the angiography with general anesthesia and apnea, because you are possibility to check CUR, the anastomosis at the same level. Most of neurointerventional radiologists don't know this point, and this is the reason why after embolization, the patient develop paraplegia. First, you check every level, you are anastomosis of the spinal cord and anastomosis. And the second point is the goal is see your embol going to the vein. It's important going in the initial part of the vein, not total vein. One discussion I think is not true. Every patient, every neurointerventional discuss to put the patient after embolization with heparinotherapy. No, it's not true. See, the thrombus is the vein. You are sure the patient continue with paraplegia. And finally, the best election is, for me, the surgery. It's not the endovascular. But I understand the patient like, no, I prefer to treat it with endovascular. Okay. See, it's the good situation. It's possible one time, not 3 times. And the important is to coagulate the point, the junction of the glomis, because the dural fistula in the brain is the same of the spinal. It's a small glomis in the dura, and then you have the drainage vein. And the surgeon open the dura, coagulate it, put a small clip, and the solution is, and don't touch the vein. This is the difference. And the last comment is, in my experience, the onyx is contraindicated to every vascular malformation of the spinal cord, also the dural fistula. Okay.
Okay, great tricks and great experience. Thank you, Luis.
Okay, very good. Any more comments, questions from the panel? Step forward.
Hello.
Go ahead. Hey, how you doing, Victor?
Hello,
Hello,
Dr.
Victor.
Puka and dear professors from Shengshu. I am very happy to see you again in this way. Congrats. Really nice surgical procedure. And I think that diagnosis is not easy. So surgical procedure is also difficult. Only in expertise hands to make this kind of surgery. So congrats. I hope to see you very soon.
Yeah, when the war is over, then we meet.
Yeah.
And the Corona war is over.
Yeah.
Yeah, Victor's done a lot of work in spinal anatomy. Any more comments, questions from the panel? Step forward.
John, one final comment or
Okay.
another comment.
Okay.
Is in my experience, I have more than 20 and a half patients treated with dural fistula, but never, only I have 2 cases. You are the different level at the same time. This is possible, point 1. And the second point is very strange. I don't have case of the cervical region in C2, C3, C4, C5, and C6, and C7. All fistula is the foramen magnum or T1 to back, no in the cervical region. I don't know why. You are experiencing China with the dural fistula in cervical region?
Professor Xu has a large series, more than 30 cases, 35 cases. We try to publish them.
C2, C3, C4?
Just at a C1 and C2.
C1, excuse me, sorry. C1, C2 is the anastomosis, meningeal anastomosis of the atlanto meningeal anastomosis with the pharyngeal, blah, 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 spinal artery of the 11. Okay, but C3 to C7, I think it's difficult.
I have 3 cases.
C3. Very
That's
interesting.
3 cases.
Oh, very interesting.
With C7, yes.
Yeah,
From C3 to C7, I have 3 cases.
Fantastic. It's the first time.
Okay, very good. More comments, questions from the panel?
Yes, sir. Can I ask, sir?
Go ahead, Mohammed.
In case of feeder from the multiple level, in addition to the main feeding fistula zone, what are the treatment strategies he has used to treat this patient in different level, the fistula from the different level, how he treat this patient?
Different level. Different levels. I never saw them. You have some case?
I just counted 2 cases. I have 2 cases. For example, one patient have a DAVF at the thoracic level, and another one at the sacral.
And one sacrum.
Yeah, at the sacral. Yes. Another is a sacral DAVF. So I treat the thoracic DAVF by open surgery, and another one by endovascular method. Yeah.
Did that answer your question, Mohammed?
Yes, sir.
You should treat both.
Okay, very good.
Good evening. Can I ask one question?
Yeah, of course.
Dr. John?
Of course.
Yes. Good afternoon, professors. My question is basically a bit out of the dural AV fistula, which we were discussing. I wanted to ask, do you recommend any surgical approaches or surgical treatment for other kinds of AV fistula in the spinal region, like perimedullary AV fistula or type 4C AV fistulas? Because we've had 2 cases in India, in Mumbai, where one in the cervical region and one in the conus, where we've approached surgically rather than going endovascularly, which is commonly believed through the papers that 4C is treated by endovascular treatment. Any comments on that, sir?
You comment on that? Did you catch it? Yeah, this is Indian English. Can you repeat the main point of your question a little bit slower?
Yeah, slow,
Yes.
please.
Yes. My
Sorry about
point
that.
of question. I'm really sorry. I know we are discussing about dural AV fistulas here, but my question is, do you recommend or do you give any surgical approaches for different kinds of AV fistula, like type 4C AV fistulas, which are pial AV fistulas, which have high flow AV fistulas, where different papers have been suggesting endovascular management? Do you recommend surgical treatment for these cases, or do you recommend hybrid treatment for these cases? One. And second, if we recommend surgical treatment for these cases, how safe is it? We've had 2 cases in India, in Mumbai, one in the cervical region, one in the conus, where we have surgically operated and found to have complete obliteration, but we've not been able to find any literature regarding it. So
Then you have to publish, then you have literature.
Sorry, sir?
Then you have to publish your own case, then you have literature.
I agree, sir, but then any comments on approaching it surgically rather than endovascular?
In big countries like India or China, you can see that kind of rare cases. I have never seen that kind of case in my life, and maybe I will never see it, but Professor Xu will see here in the big population. So maybe he could have an answer, but he told recently that he had you should treat both, and if both, so and he had a double lesion, so he treated one by surgery and one by endovascular in the same patient. So, but these are cases you could publish. You should publish these cases. So because they are rare, no one has seen them in any other country. So these are. I showed my experience from Helsinki. 15 years, 19 spinal dural AV fistulas came, and this is the only center in southern part of Finland. So you can see that how rare they are. And then if you have a rare case with 2 fistulas, which you classify classify somehow, I have never heard. So you should publish, analyze and publish. So these are rare cases. If you have 2 of them, so other persons, doctors are benefiting. Then you find in literature. So this is your own case, very, very rare case. And Dr. Xu had also 2 double cases. So you should publish. I encourage very much to publish, because then you will find in literature more cases.
All right. Thank you, sir. Thank you very much.
Thank you for the question. More comments or questions from the panel?
I just want to say hi to.
Go ahead, Hugh. How are you doing?
Hello.
Hey, how are you doing, Professor Xue?
Hi.
Good to see you again. Yeah? Long time. Hope that we can meet soon. Very good.
We do our best to get you here.
Yeah, very good talk today.
Yeah.
Where are you at, Hugh, now? Where are you at?
Germany.
Oh, okay. Could you please introduce yourself, Hugh, just to the people?
Sorry?
Could you please introduce yourself to the audience?
So I'm Hugo Andrade. I work also in Henan Provincial People's Hospital in Chenzhou with Professor Xue, Yuha, Donchan, and we have been always collaborated also with Dr. Kian and Dr. Victor Hugo. So yeah,
very good.
Now I'm trapped in Germany.
Very good. Nice to meet you.
Nice to meet you.
Okay, very good. I guess any more comments, questions before we close and move on to the next presentation with Dr. Kian? Oh, go ahead, Joanna.
Yes, hi. First of all, huge thank you for Professor Hermesniemi. Amazing presentation as always. For the spinal AVFs, they're not so familiar for me, so I have one question. If you have dural AVFs in anterior fossa, then the surgical resection is more straightforward. But in case of spine, is there any other reason than the location of anterior spinal artery in case to go ahead for surgical approach and not to do embolization? Is there any other reason for that?
You have bigger experience, Professor. Surgery or endovascular? What is the better? Or you have to select every case?
How to select?
Yeah, how to select?
Generally, I selected the open surgery. Only the patient who can't tolerate the open surgery will do the endovascular method. But I know about 70% of patients can be cured by the endovascular surgery. But the doctor must have many experience. So that's all.
Okay. So you can do both. So it depends on your experience and where you are doing the best treatment. So we thank all.
Hello, sir. Hello, sir. Hello, sir.
One more question,
Yeah, okay.
Yes.
Okay.
Can I experience our experience? Can I share our experience regarding perimedullary fistula?
Sure.
That was asked by the Indian guy. In Bangladesh, we have treated, we got too many spinal dural fistula, especially the dural fistula and the perimedullary fistula also. We have got experience of two interesting cases of perimedullary fistula, one in the cervical region and another in the conus area, another in the lumbar area. In our experience, we have treated two patients in hybrid approach, initially endovascularly, then followed by microsurgery. In cervical region, there was a big venous aneurysm inside the cord that ruptures and patient presents with quadriplegia. That patient has got that is type 4C patient having multiple feeders with high flow fistula in the cervical region, having both anterior spinal artery supply and the both bilateral posterior spinal artery supply also. We have taken the posterior spinal artery with the venous aneurysm with surgery, and before that we have taken the anterior spinal artery part with the endovascular way. In the same way, we have taken the lumbar perimedullary fistula also. The anterior that means the supply from the anterior spinal artery we have taken endovascularly, and the posterior spinal artery supply we have taken by microsurgery. That is our experience. We have taken both the perimedullary fistula with hybrid approach. That means initially endovascular from the anterior part, then from posterior we have taken the posterior part by the surgery. Because the anterior spinal artery is very difficult to target through the microsurgery, because the anterior spinal artery is very anteriorly, it is very difficult to approach from the posteriorly. So we have taken that through endovascular way, and the posterior aspect is very easy to take by microsurgery. For that reason, we have taken that particular posterior feeder by the posterior microsurgery. Thank you, sir.
Have you published the study, my friend?
Waiting for your publication.
Yeah.
Have you published it, my friend?
Good answer.
Yeah, we are preparing our cases for publication. Yes.
That's
Thank you.
Okay, I think we have to wrap it up. I think you has things to do here. Okay, thank you very much.
Thank you very much, John.
Thank you. We'll see you next week.